Dr. K.G. Kobegala from National Hospital, Kandy, and she will talk to you on Dapsone-induced stress syndrome with concomitant thyrotoxicosis. Over to you, Dr. Kobegala.
Thank you very much. I would like to begin by thanking Anti-Leprosy Campaign for the given opportunity. Dapsone-induced stress syndrome with concomitant thyrotoxicosis, a rare drug hypersensitive reaction in leprosy treatment. I am Dr. K.G. Kobegala, acting consultant physician, National Hospital, Kandy. What is stress syndrome? Drug reaction with eosinophilia and systemic symptoms. This is a severe idiosyncratic drug reaction characterized by eosinophilia, lymphadenopathy, visceral organ involvement, and atypical lymphocytosis. The disease carries mortality of 10% and has a close association with other diseases of autoimmune etiology. The disease is recognized to occur following the use of certain drugs more than others. One of them being the Dapsone, which is commonly used in treatment of leprosy. The disease is known to cause complications such as limbic encephalitis, thyroid disease, renal failure, phrenic rupture, eosinophilic esophagitis, eosinophilic colitis, and complicated CMV disease. Breast syndrome associated thyroid disease and endocrinopathy is recognized. Hypothyroidism is more common, although cases of hyperthyroidism are also reported. The latency between the first exposure to the drug and the onset of symptoms can range from 2 to 8 weeks. The condition differs from typical drug reaction as it may persist and even worsen despite discontinuation of the drug. Although eosinophilia is included in nomenclature, it is present in 95% of individuals and atypical lymphocytosis in 27 to 67% cases. Thus, in a patient coming with breast, the diagnosis is not always straightforward. Nevertheless, early treatment is mandatory and should initiate without delay to avoid complications. As such, high degree of clinical suspicion is necessary. We present a case of 4 to 5-year-old bus conductor presented from Kurunegala. He has noticed hypopigmented anesthetic patch on his back, and upon referral to dermatology, a histological diagnosis of multibacillus leprosy was made. At this point, the patient was not febrile. There was no organomegaly, lymphadenopathy, or biochemical abnormalities in his basic investigation. The patient did not have systemic symptoms or fever. Following commencement of anti-leprosy treatment, he was commenced on multi-dapsone, rifampicin, and cofacillin treatment. Following commencement of anti-leprosy treatment, he complained of progressive low volume loose stools with increased frequency of defecation 8 times a week. He had also lost 20 kilograms of his weight, which was initially 70 kilograms. At 21 days of treatment, he developed CA symptoms, and by 5 weeks he developed severe arthralgia and myalgia. On day 38 of treatment, he developed yellowish discoloration of his eyes associated with high spike fever and rash, and admitted to our unit. On examination, the patient was thin-billed, anxious, and clammy with high-grade fever. He was pale and itchy. He had palpable goiter with prominent left lobe without overlying growth. There was generalized lymphadenopathy and large firm lymphadenopathy from 1 to 2-3 cm size, which were non-tender. He was struck with continuum erythema in keeping with erythroderma without this formation. He had hepatosplenomegaly. In addition to, on examination we noticed hepatomegaly, and in ultrasound scan he had mild splenomegaly as well. He was having tachycardia of 120 beats per minute with collapsing pulse. His investigations revealed high white cell count with lymphocytic predominant initially, later progressing to eosinophilia of 30%. His pulpit count prior to admission has been consistently pancytopenia. His CRP was 62% with normal ESR of 26. Blood and urine cultures were negative. Liver function showed cholestatic pattern with high transaminase, AST more than ALT pattern. He had CSH less than 0.15 and T4 more than 90%. Ultrasound of thyroid gland showed diffuse enlargement of gland with cause echogenicity and increased vascularity consistent with goiter due to thyroiditis. Ultrasound of abdomen showed moderate hepatomegaly with mild splenomegaly. Blood picture showed atypical lymphocytosis, and bone marrow aspirate was consistent with hypercellular marrow with normal cell count consistent with reactive marrow without evidence of hematological or non-hematological malignancy. His Vandu and sputum ASB tests were negative. 3 samples were negative. Retroviral, hepatitis B, C, VBRS was negative. He underwent 2D echo. Didn't show any evidence of infective endocarditis, and he had TPO antibody more than 500 international units per liter. He had multi-organ, according to this, he had multi-organ involvement involving GI system and thyroid system, and as well as systemic symptoms with fever. So the diagnosis of breast syndrome was associated with Dapsone was made according to registrar criteria. To diagnose breast syndrome, there are different scoring systems are used, Japanese criteria and registrar criteria. Registrar criteria is more widely used. We apply registrar criteria to our patient. Our patient had total score of 9. It is giving definite diagnosis of breast syndrome. Initially, he was started on carbimazole 20 mg BD and propranolol 20 mg BD, and we initially stopped all anti-leprosy drugs. And despite the treatment, thyroidotoxicity and fever did not resolve. He was running high spikes of fever, and the patient was deteriorating his condition. Thus, we arranged an early bone marrow biopsy, which to prevent changes of bone marrow changes associated with steroid, and we pulsed him with methylprednisolone 1 gram for 3 days, and later converted to oral prednisolone 4 to 5 milligrams per day. He showed dramatic clinical and biochemical improvement with steroid therapy. There was splenomegaly, lymphadenopathy, and fever resolved, and we gradually scaled off prednisolone, and he was discharged. He was referred back to the dermatologist team, and antidepressant medical treatment was started without Dapsone with ofloxacin-based regimen. During subsequent clinic visits, his eosinophilia resolved, and all his biochemical investigations gradually came to baseline. So, in conclusion, breast syndrome being an atypical and rare drug-related hypersensitive reaction with autoimmune basis can occur with considerable latency period. The heterogeneous nature of presentation can mask the primary disease and can cause delay in diagnosis. So, breast syndrome is potentially life-threatening. So, some clinical recognition is essential to start early treatment. Thank you very much.
Thank you, Sobekula, for that presentation. We have time for few questions.
Thank you very much for that wonderful presentation. That's a good question. Now, breast syndrome, whether the patient was admitted to the medical ward, diagnosed there, or was he admitted directly to the dermatology ward and diagnosed?
Sorry, I couldn't hear.
Yeah, where was the patient diagnosed initially? Was it in the medical ward or was it in
Leprosy was diagnosed in Kurunegala Dermatology Clinic, and breast syndrome was diagnosed at National Hospital Kandy, medical ward.
As you mentioned, this is a fatal condition we encounter. So the most important thing is to diagnose it early. That is the single most important factor in saving his life. Immediately we have to stop and start on high dose of prednisolone, and we have to work in collaborating with GI physicians. They help us a lot in managing. Sometimes they need max therapy and to save the life. So to conclude, I will hand over to my.
One more thing to add for this breast syndrome, not only for this death zone, I think everybody is aware, as doctors, the fever as an organ involvement. That is the kind of breast syndrome. So often it is suspected as viral fever. There is fever enzyme elevation, rise, and fever. So often this is not diagnosed in time. So remember, if the patients have potential drug, with fever as an organ involvement, maybe often elevation and elevation, just brings the possibility of breast. So we have now come to the end of this presentation. So thanks you to all.